So I just wanted to welcome everyone to the March Humanity and Healthcare series. And I just want to make sure I can click, there we go. Just thought we'd start off today by recognizing that those of us attending from the Kingston area are situated on the traditional Anishinaabe and Haudenosaunee territories. I just want to say on this third day of spring, I give thanks for these lands. And looking out the window, it's hard to believe, but there are some little signs of spring out there, and just give thanks for the time that we have given ourselves in the next hour to be present in the moment on these lands. As we collectively reflect on stigma in healthcare, and really thinking about stigma as a fundamental cause of health inequity and how we can work to bring humanity to our everyday interactions. So my name's Catherine Donnelly, and I just want to welcome all of you here today. And I'm one of the members of the Planning Committee, along with Damon Dagnoni, Ernest Snellgrove Clark, Hugh Wiley, Shana Watson, and with the support of Queen's Op-Eds, Jennifer Copland and Terry Solius, who are here today. So thanks, everyone. But more importantly, I feel extremely fortunate to welcome Ian Clark as our speaker today. I had the privilege of hearing Ian speak at an aging conference at Providence Care in those days of in-person conferences many, many moons ago. He spoke about poverty and aging, and I was struck at the rawness in which he spoke and of the stories he shared of people living in poverty, and it struck me. And I've tracked him down here to see if he'd speak to us all today, and I'm so delighted he agreed. And so I'm pleased to introduce Ian. He was the president of the Coalition Against Poverty. He's a poverty advocate and works at Harbor Light Residential Treatment Program. I'm going to stop sharing my slides here, Ian, so I can actually see you in person. So you bring a unique set of personal and volunteer and work experiences to our conversation today. So I just wanted to get you sort of warmed up by having you tell us a little bit about your background.
As you said, I've been an anti-poverty activist for about 10 years. I was the president of Kingston Coalition Against Poverty for, I want to say it was 3 years. I was a member for 8. I work at Harbor Light Addiction Treatment Center, and I sort of sometimes refer to myself as sort of a lifelong boundary non-haver, which I'm going to have to qualify at some point. But essentially what it means is, in a lot of ways, I feel like my sort of personal, professional, and activist lives have never really been that distinct from each other. And I think that kind of informs my perspective. I think probably the best way to explain what I mean by that is kind of just to tell a bit of my story. So I was diagnosed obsessive compulsive at age 18, with it kind of being heavily implied that I might also have some sort of a mild atypical autism. The sort of combination of which, and sort of a lot of things that I was kind of going through just in my personal life at the time, led me to drop out of university before I turned 20. Which by pure coincidence was around the same time the G20 summit was happening in Toronto. A bunch of my friends who I knew from school wound up actually getting arrested and detained without charge for a couple of days. And so there was a march scheduled to sort of protest that, and that was where I first became acquainted with sort of a lot of Kingston's activist community, but also KCAP specifically, which was at the time sort of a pretty radical sort of civil disobedience heavy anti-poverty group. I didn't really join officially for a couple of years, but this kind of left me sort of having just dropped out of university, having sort of trying to enter the workforce, and sort of going through the experience of being sort of finding myself in the working class, while also being sort of brought up in the world of what I would call radical anti-poverty activism, which was interesting because it gave me sort of a lot of lenses and sort of ways to analyze kind of what I was going through myself at the time, as well as the chance to meet a lot of people who were experiencing poverty like I was, and a lot who were experiencing it quite a lot worse than me, like several times worse than me. And kind of to get to know them, as some of my best friends. And it struck me sort of how much our experiences had in common, but also how much they didn't, not just in terms of the degree, but in terms of the specifics. And so around the time I became sort of a full-fledged part of KCAP, I started going back to school part-time, and also sort of by coincidental timing, I started sort of really accelerating what I would call sort of another fairly common working class experience, which is rapidly changing roommate situations. I moved in with a friend. She moved out, replaced herself. They moved out, replaced themselves. They sort of repeat and over again until I actually found myself, unbeknownst to me, living in a crack house. one of the roommates who replaced themselves vouched for the person they were replacing themselves with, but I think unbeknownst to all of us, he turned out to be a drug dealer with a pretty extensive violent criminal record, who made it pretty clear early on that since my name was now the only one on the lease, he wasn't going to let me leave without a fuss. Um, Thankfully, after about a year, I was able to escape. I got out. I was kind of struck with both the relief that I managed to make it out alive and unscathed, and sort of really that I managed not to fall into sort of the lifestyle that was surrounding me at the time. But I was also a little bit disappointed that I wasn't really able to help anybody who I'd met in this whole thing. Um, which was when I decided that if I was going to go back to school, seriously, I was going to take psychology and I was going to try to enter the mental health field. And kind of try to do some of the work that I hadn't really been able to when I think I really had wanted to, in the moment. And around the same time I met my wife, which kind of between her, her support and the fact that I think my life had kind of settled down a little bit, I was able to go back full time to finish my degree. Bounced around after that a couple of sort of post-graduation, minimum wage retail jobs where you're waiting for your actual sort of break, which wound up actually paying a lot less than the delivery driver job I've been working in my 20s, which was also a lot more physically taxing. I know sort of the last time that I spoke, I talked about a recurring knee injury that I developed from standing on uneven floors for about 6 hours straight. And of course, while all this was happening, my wife and I kind of ended up being essentially handed leadership of KCAP, where we kind of decided to take it in a bit of a different direction, becoming a bit more accessible, a bit less militant, a bit more sort of in favor of starting conversations. I have nothing against the sort of more militant, sort of civil disobedience, heavy style activism. I think a lot of times it can be the right approach. It's just not my style personally. And we wound up finding a niche that I think wasn't really being filled locally. We had a lot of sort of loud groups blocking off Princess Street, and we had a lot of sort of awareness campaign type movements that were almost a little too not aggressive, to the point that it sometimes felt like they weren't actually pressuring anybody to do anything. And sort of somewhere in the middle of that, we kind of found ourselves as sort of this very unfulfilled role as a group, sort of largely comprised of people who, most of us had the lived experience. We had some bold policy proposals, and we could speak very earnestly about the urgency involved, but nevertheless, we kind of made ourselves a group where people who maybe didn't know as much about these issues could feel safe having those conversations with us. We were able to, I think, I'd like to think we played a role in sort of some of the policy change that has come sort of in the last few years towards sort of maybe not as much as needs to be, but sort of reversing a little bit of the cutbacks that we've seen to services for homelessness in Kingston. And sort of once we were comfortable there, we wound up folding the group, because I think there were only 3 of us left at that point, which was about when I got hired at my current job, which was kind of an immediate trade-off in terms of lived experience. I was no longer poor, but I was now working with a population who had experienced some of the most extreme forms of marginalization, and getting to hear a lot of their stories. And sort of between having lived some of it, but not necessarily nearly as badly, but having, between that and sort of having advocated for years and sort of now working professionally, it kind of struck me how sort of many common themes there were throughout sort of everything that I was seeing, personally, professionally, and in my activist life. How I kept encountering these same experiences of people, hearing the same stories of people dealing with institutions, whether we're talking about, corporations or social programs or healthcare. I'd met a lot of people living a lot of very different lives, but I did sort of notice there were a lot of very similar stories.
And I know when we spoke in preparation for today, the concept of stigma runs through all of the stories that you're going to be sharing today. And, when we started to talk about stigma together, we also started to talk around the word about the concept of humanity. And, even though the series is called Humanity and Healthier, we haven't actually spent a lot of time dismantling what that means. And I'm just curious, I know that you have your own view of humanity and wanted to share sort of that concept to the rest of the group.
So I know sort of usually I think when we talk about humanity, we're sort of talking about this notion of human dignity and holding space for recognizing that, the inherent worth that everybody has just kind of by virtue of being human. And I think a lot of really great and important conversations can happen there. And I mean, they have been happening. I think this series so far has been fantastic. And I'm not going to completely sort of divorce myself from that definition. especially because to that end, I think there's definitely a lot of space to talk about stigma in terms of how it can cause and how it can reinforce sort of negative thoughts about members of particular groups, and how that can sort of make it challenging to maintain that level of empathy and respect that we talk about when we talk about humanity. But in this case, I think I kind of want to look as well at sort of a different aspect of humanity, and that's what I would call the three-dimensional aspect of humanity. So I'm about to say a really, really non-controversial statement. Human beings are complex. We have all kinds of complex emotions and desires that sometimes kind of contradict each other, and sort of infinitely intricate motivations and goals and fears that all kind of constantly bump up against each other. And they create really this writhing mass of human psyche that we've really been trying for centuries now to kind of map out. And we've not really gotten any farther than sort of, here's how we think it might work. But what stigma does, like any stereotype, is it takes our mind's conception of how complex any given individual must be, and it kind of flattens it into this two-dimensional or sometimes even one-dimensional fraction of itself. And whether consciously or not, we reduce what we know to be potentially thousands of factors that can comprise a human being into one or two. There are certain characteristics that when we learn a person possesses them, we don't so much treat it as one factor that we add to our conception of them. We take it as an excuse, often subconsciously, often even if we're trying as hard as we can not to. We kind of take it as a reason to start stripping away all of the other factors from our conception of them. And I'll give you one example. I know we're planning on sort of getting into addiction a bit more in depth later. That's professionally my field, but there's this phrase that I keep hearing, in that field. Thankfully, not from any of my coworkers or supervisors anymore, but I hear it a lot sort of from material and elsewhere in the field, and sort of in sometimes when I see old material that we used to use. And that phrase is the addict's mind. It's always used to make pretty sweeping statements. You'll hear like, in the addict's mind, you can rationalize X by, or, in the addict's mind, they can't see that this is harming them. And, every time I hear it, I kind of think to myself, well, what the hell is an addict's mind? How can a single factor like having a chemical dependency or, on a drug cause every single person who experiences it to have a mind that works in the same way and comes to the same conclusions? And I mean, the short of it is I've met hundreds of addicts, spent 40 hours a week for 2 to 4 months straight with most of them. And the one thing I can say with absolute certainty is their brains do not all work the same way. There's as much difference in personality and cognition and thought patterns in a room full of addicts, whether we're talking about recovering or non, as there is in any room full of people you would just pluck off the street. But when we look at what stigma does, it takes sort of one thing about someone and causes us to blow up that one thing in our minds until we believe that makes up the entirety of the person. When most of the time, not only does that single factor make up only a small part of who that person is, but even the way that we view that one factor itself can sometimes be oversimplified and kind of singularized. Something like poverty or addiction or mental health, a person's weight, a person's disability, a person's cultural background, any experience they might have with racialization, their gendered experience, sexuality, religion, these are all things that interact with every other aspect of a person's personality and humanity to make up not just an infinitely complex person, but an infinitely complex and varying experience of that singular factor itself. And so I think that's what I mean when I say the three-dimensional definition of humanity.
And I know, just even as coming up with the title for the talk too, this idea of this costume, this thing we wear, this dimensionality. And when we talk a lot about these intersectionalities, I know we spoke about this idea of like the social determinants of health that we hear about and talk about a lot. Mm-hmm. And obviously the recognition of the influence of the environment on health. Your thoughts on, how we use the term social determinants. Sort of, it can be a bit reductionistic, and just sort of your own reflections on that.
Yeah. So I think before I get into sort of what I would call some of the issues and limitations that I see, at least with how social determinants of health is used in practice, I do just want to say first off that I definitely think that moving toward recognizing social determinants of health is an incredibly positive and important step. And in discussing limitations that I think exist in practice, I want to make sure that I don't minimize what a huge step forward it's been to put more focus on the concept, and the immense amount of hard work that so many people have done to make that a reality. And I definitely don't want to suggest that we should stop doing it. And I kind of want to emphasize that what I'm about to say, sort of in terms of my criticisms of the limitations, definitely apply to the way that it's done in practice sometimes, and not the underlying concepts. Because I think that the theoretical framework we have in place for SDOH is really solid. Where I do have some concern sometimes is that when I look at specific screening templates that are used in a lot of medical practices, they tend to sort of fall into one of two categories. Either they'll go really in depth on one particular determinant of health, but not really touch on others, or the opposite, they'll kind of touch on all the basics, but they'll cover each sort of determinant, but they'll often reduce each one to one or two, on a scale of 1 to 10 kind of questions. And in the former case, well, I think that does a really good job sort of avoiding what I was talking about earlier with the sort of flattening of that one specific aspect. It still tends us toward flattening our conception of that person to being that one specific aspect, even if it keeps the aspect itself three-dimensional. Well, in the latter case, the scale of 1 to 10 screener sort of case, I think what it can do is it can tend to cause us to miss some of the complexity of experience that could be contained within each social determinant of health. And I think in both cases, the danger lies not so much in doing the screeners, but in treating the screeners as being kind of doing the thing, as opposed to just being the introduction, the sort of initial base into which we can delve into a further exploration of the ways in which particular hardship or adversity might be impacting someone's life or their health. Because if you have a screener that, say, someone ranks an 8 on economic insecurity and, say, a 6 on experiencing racism, there's a story there. There's probably actually like a bunch of stories. And if our next step isn't to find out what the stories are, or at least how they're relevant to that person's health, then in our heads, we're probably just going to fill in our best guess. And our best guess is going to be based on some level of stereotype, which in some level is going to default to stigma, even if we're trying very hard not to make that the case. It's just subconsciously, it can be almost unavoidable. And then inversely, we could have an SDOH screener that focuses on poverty, and it tells us a bit more about that person's story with poverty, whether they're hungry, whether their income is insecure, but then it might miss out on other details like, is their poverty manifesting in such a way that might make them feel at risk for sexual exploitation, or is it being made made worse by any experience of racism that they might be going through, or are they having to maybe hide an aspect of themselves to maintain a precarious living situation that they might not have to hide if they were able to support themselves independently? And all of those things can make even just poverty itself look very different for one person who might be experiencing, say, the same level of things that screener does measure. It might be the same results, but two very different experiences.
Mm-hmm. Again, sort of always that caution of not flattening the experience and using them as a way to start a conversation, not to end the conversation. Mm-hmm. I'm just going to stop and pause there. I feel like you've covered a lot of ground and given us a lot of food for thought, and just wanted to open it up if there's anybody on the call, or feel free to put some comments on the chat. At the same time, I know we've got a lot of ground still to cover in. Okay, Shane, I don't know if you had a question, but I'm going to keep continuing on, Ian, because I know that we really wanted to dig in a little bit more also about, so much of the Humanity in Healthcare series has really focused on this idea of the individual practitioner, the health provider, and the individual. Whereas when we think about health, just flowing from this idea of the social determinants and the larger environment that we sit in, the health of communities and how communities can be healthy or unhealthy and can help support people. And just thinking about your work with the Coalition Against Poverty and focusing specifically in that coalition on communities, just your thoughts at that community level that you've been working at for so long and as an advocate.
Well, I think sort of talk about community, and I think sort of to bring it back to sort of how can community be used a couple different ways. I think if we're talking sort of about sort of bridging the gap between that community activist experience and sort of the healthcare provider experience, I think I would probably talk about that in two ways. The first is that when we talk about stigma specifically, I think that community can play the biggest role in how to break that down, particularly getting immersed within communities. Because I think the best way to teach yourself how not to look at someone just as a stereotype, more so even than just conscious effort alone, to look past the stigma that we overlay on someone, even when we're trying really hard not to, is to really kind of immerse yourself in what to do instead of that stigma. To really break down that stigma, we have to get to know people. We have to not just memorize the facts and figures in the studies, although consuming research is obviously a vital part of it. But we have to get to know people as people. with some caveats. So when I referred to myself earlier as being a lifelong boundary non-haver, I should probably clarify that I definitely didn't mean professional boundaries. Um, Obviously the professional boundaries that exist in the field of healthcare are definitely important and definitely exist for a good reason. So I'm not suggesting that we need to break down those barriers in terms of individual patient and care provider relationships. I'm talking more about the boundaries that we set up in our heads when we designate a group to be us and a group to be them. To some degree, we can't help it. It's kind of just how our brains are hardwired. But I think that what we are in control of is how much distance we put between the in-group and the out-group, and how much similarity and continuity we see between ourselves and the people that we are, for whatever reason, kind of forced to see as that other group. Because I think that where we really see stereotype and stigma start to foster is when we start allowing ourselves to go beyond merely seeing an out-group as different, and we kind of start seeing them as alien. And I think that's where community can become vital, because while we can't directly interact with patients in ways that kind of break down those barriers that we sometimes have to keep in place, what I think we can do is become part of their communities, at least in a broad sense. I'm definitely not suggesting that you start going to patients' kids' soccer games, but about sort of the communities that they might be a part of that are sort of made up of the same group, so to speak. If you really want to know what the experience of a low-income patient on a day-to-day basis is, for example, you can start with something as small as just frequenting a business in a low-income neighborhood, somewhere where people hang out, like a grocery store or a convenience store. Actually, convenience stores a lot if it tends to be in a food desert. It can be things like starting to come out to neighborhood events there, or even better yet, volunteering to help organize them. And really, I can't stress enough, if you have the time, volunteering can be such a great way to meet people, especially if you make sure that you find an organization that does work in a non-hierarchical fashion. I find sometimes a lot of the sort of charity with a capital C type groups, while they do a lot of great work, they can operate in ways that kind of enhance that division between the have and the have-nots. And there are a lot of groups that employ policies that really help to not fall into that trap. And I think if I had to think of an example of a group right here in town that I think gets it right, I would definitely say HARS. Everything that I've seen from them, whether it's the center in Princess Street or the integrated care hub, it does as much as possible. It's done with this sort of idea of mutual humanity in mind. But I think, oh, sorry, good.
No, I was picking up this idea of the mutual humanity, because in a couple series ago we talked about, Deji spoke about the power of volunteering, and he didn't speak specifically about this sort of flattening and this mutual humanity, but as you speak of it sort of as strategies of how we can make connections and mitigate stigma, it really resonates with me specifically.
Yeah, I think there's a phrase that I really like, which is solidarity, not charity, which really taps into the idea of helping people from the perspective not of, I must help these people because I'm part of the haves and they're part of the have-nots, but it's more, I must help people because they're the same as me. We're all part of the same group. I just happen to be on a different end of that group than they do.
Mm-hmm. Mm-hmm.
I happen to have something.
Mm-hmm.
Usually, primarily, I think most of us, to a large degree, through circumstance, that they don't have, and so it's just that balancing of the universe almost.
And I know we spoke a lot about poverty in preparation for today, and it sort of lends nicely to switching to hear some of your stories about the complexity of poverty and the layers of stigma that result from that. And can you share with us a few stories that you bring?
Yeah, for sure. So I think I'd kind of want to just sort of put, if I can, before I go into the individual stories, sort of a unifying factor on where I think poverty and stigma can kind of come into, can kind of play off of each other. I think that we have a tendency subconsciously to blame poor people for their own poverty, even when we're trying really hard not to. And what I mean by when we're trying really hard not to is I think the sort of the Reagan era pull yourself up by your bootstraps mentality is thankfully mostly absent. But I think a lot of the time there's this tendency to, even if we don't blame somebody's choices, we still find something about them to blame, whether it's sort of, we assume that they have some sort of innate lack of intelligence, or they just don't have an education, or, or they, swear I had a third example. But in a lot of cases, I think the underlying truth that can get missed there is that a lot of people are poor because somebody had to be. Because the way that our system is set up is really set up that there's only a set number of people who can live outside poverty, and a lot of the time, someone can sort of check off all the boxes that we would associate with not living in poverty, and they still don't get there just because there just weren't enough spots, not even at the top, but at everywhere else, sort of down the chain, so to speak. I can definitely say I've met a lot of, I would say probably the majority of people who I've worked with, I think that is the case. There's no explanation I can think of for why it is that they're living in poverty other than there just wasn't enough opportunity to go around. I actually remember reading a story a while ago about there was a Walmart that opened up in a small American town, and the number of applications that it got, and this would be obviously primarily minimum wage, and especially American minimum wage, so not even out of poverty sort of jobs. But the number of applications that it got compared to the number of openings that it had was actually a greater ratio than that of Harvard University. I think we're living in a world where good jobs are dwindling, even bad jobs are quickly disappearing, and wages relative to inflation keep falling.
I think we forget as healthcare providers, we're all in this position of utter privilege, just the very nature of the job, the jobs that we have as well. And Shane, I know that you were commenting and reflecting just as a family physician, and just Ian circling back to what you talked about check boxes and the social determinants, sort of, here's before I see a healthcare provider, I fill out this form, and how do we then have meaningful conversations? And so much of healthcare is structured in these 10-minute blocks. Not all professions, but some of the medical professions, particularly with the way things are structured in billing. And Shana, just sort of your comments from a family physician perspective as you hear this.
Yeah, I'm intrigued by the way you frame it, Ian, and I'm in family medicine. We try and see the whole person, and yet we work in a system that is everything we do is to try and narrow things down and make it manageable. And so there's this tension between embracing the big and narrowing things down through questioning and working up problems to make it a definable problem and a solution. And I'm just curious, and maybe this isn't the right place in the time to ask what your thoughts are on this traditional medical model and how we can challenge it a bit.
That is a good question. I think definitely you speak to the fact that I think the majority of change needs to be systemic as opposed to just people trying to change on an individual level. Because I think, as you say, I think the effort is overwhelmingly to try to see the whole person and try to overcome a lot of the barriers that I'm talking about. As far as what sort of a better alternative would look like, it's hard to say. As a radical anti-poverty activist, my gut instinct is just to blame it all on capitalism, but I'm not sure if I can actually do that.
Well, we can do that.
I don't know if I can put it into words or actually substantiate that.
And you know what, Ian, I think, because I've so thoroughly enjoyed our conversations leading up today. I think it's shifting our thinking, and I think we get so entrenched in this deep medical model that we forget the power of the social structures that we're living in that really are presses in how we create connections with humans in healthcare.
Mm-hmm. And I'll just add on to say that sometimes I feel like the thing that we can do is offer the opportunity to know and be known. And so when you spoke about sort of that we bring ourselves, and and we are joining together with people. It's that sense of creating spaces where people are known and greeted for who they are, which sometimes is a bit like the old theme song from Cheers of like going where everybody knows your name.
So I'm trying to, think myself that question that Shayna asked you about, like, how, when we look at, I'm just reflecting on what I did yesterday in the emergency department and the environment that really looked like a war zone. And trying to think of, the conversations that I have both with patients, but also with all the different healthcare professionals that I work with. And honestly, like coming back to, the first half hour of listening to you speak, like it really comes back to the medical model has become so much like the hospital. The hospital will fix it, when that's not the case at all. 90% of everything should be the community. And I don't mean like, family medicine community. I mean like the stuff that you're doing, that the integrated hub is doing, that so many other groups are like, there's just so much there that, that's not my area of expertise, but it's so upsetting to see this crisis in our system that's happening. And, just the depersonalization and the terrible care that patients receive when they're stuck in the hallway, sometimes for days. And this is my experience, right? Because of where I work and how I sort of see things. But so many of us, when we do get a bit of downtime and talk about, we just wish that when there were more resources in the community, there were more opportunities to, for prevention, but not just prevention, but just community support and being able to have, I'm sorry, I'm spouting off a bit here, but more opportunity to let people tell their stories of their lived experiences, their challenges. And I'm not going to call them patients, and I'm going to say, the people that we are shoulder to shoulder with in life, and try to help solve those problems. And so much of our system is built in units. And I just see a gaping hole of community resource investment and cutbacks after cutbacks after cutbacks. And my biggest pet peeve is, it's not affecting patient care. It's not affecting people's lives. And it's so upsetting. And so I don't know if you have anything to say after my little rant there of reflection. But it's like, working in the hospital I see the end result when we don't invest in, our communities. And you had said before that, really the community you think is really the kind of at the level that we can make a difference.
Yeah, well, I think, the phrase, an ounce of prevention is worth a pound of cure, I think really is a valid one. And I think when you speak to that role that the community used to play, I think sometimes it's not appreciated enough the way that the hospital, particularly the emergency room, sort of winds up being where everything crunches when you have an underfunded system. Because when there's deficits everywhere, those deficits are going to build up and build up and build up and build up, on an individual level and sort of in the level of an individual experience, to where almost at a certain point, any pre-existing issue is going to reach a point where it can't be ignored anymore, but it's also too urgent to do anything else. And so that definitely all ends up. My gut instinct kind of when we started talking about the emergency room was to say that I think a lot of what I'm saying almost shouldn't have to apply at the emergency room. But it does. And I think that's the result of cutbacks everywhere else. And then also cutbacks, of course, happening at the emergency room. And hey, I did manage to blame it all on capitalism. But I think it's true when we talk about sort of how to fix an overtaxed healthcare system, overtaxed obviously not in terms of tax revenue, I think quite the opposite. There are so many things when we talk about community programs, when we talk about resources for people living in poverty, that even in preparing for this today, I didn't think of as being part of the healthcare system, but that's actually a really myopic way to look at it, to not think of that as being part of the healthcare system, because it's all about a person's thriving and a person's flourishing and a person's ability to live a healthy life. And I think to a certain degree, when I do talk about the need being more systemic than on an individual level, I think that's because I very, very rarely, when I talk about institutions and when I talk about the problems that I've seen people running into with them, I'm almost never talking about the person that works at those institutions. And neither is the person telling me the story, because it nearly always ends up being a case where they're trying not just their best, but the best. I think, they're the people sort of on the front line of these systems are really overperforming above and beyond what any human being should be expected to do. And they're invariably coming up against, there isn't enough time, there isn't enough money, there isn't a resource for them to suggest to somebody who's in a crisis. And so they sometimes really wind up trying to almost fill in the blanks there.
And Ian, I know we also spoke about that, you're alluding to like these structures and processes that providers, whether they're like formal health providers or in the larger community of social supports, are really stuck in. You shared a really compelling story about a friend of yours who needed to get food from the food bank. And just even that story alone and what it takes to interact with someone who's helping and what that experience is.
So I that story. So a friend of mine who I met through KCAP, we were working together on a project, and I asked if a particular day would be a good day to meet to sort of work on that. And she said, "Oh no, I can't. I need to go to the food bank." And I said, "Okay, what about after that?" And she said, "No, that's my day." And I didn't know at the time quite what it meant, but when she explained it to me sometime later, she had to get up, she had like a little cart. It's almost like a collapsible shopping cart type thing. Had to take it about 2/3 of the way across the city for where she lived to where the food bank was located. Had to get the food there, take it back, of course, along Kingston's famously terrible sidewalks. And more than that, she had a number of chronic injuries, which made it all the more horrifying. So she was living on Ontario Works, and I know when I say she had a number of chronic injuries, I think everybody's sort of gut instinct is to say, well, shouldn't she have been on ODSP then? And yeah, she should have. And so, that wound up taking up her entire day. And except it didn't actually, because she still had to go out that night and walk about half the distance that she'd walked the first time to the soup kitchen, because she had nothing to eat that night. Her check basically really only covered rent and some basic bills. And so it really kind of illuminated to me how living on social assistance, we think of it, and this I think ties back into stigma. We can sometimes think of it as being sort of a life with a lot of free time full of existential dread, so to speak. But in her case, it really was a full-time job, just getting between these institutions that were helping her. And I know a lot of conversations have been had around that as being a barrier. But I mean, I think that does sort of speak to how these institutions that exist are very much doing their best a lot of the time, but there just isn't that sort of gap bridger. The food bank exists, and the food bank's doing really a great job with the resources that it has helping these people, but it doesn't have anything within itself to help people get there if they live halfway across town.
I've seen that so many times. Programs pops up thinking it's helping, and it's not that it wouldn't on its own, but there's so many sort of upstream issues to actually make it truly effective. We talked about the multiple layers of stigma and poverty, and also talked about the strong relationship between mental health and poverty. And I know you had some examples that you wanted to share about these layers of stigma that go, with poverty and mental health.
Yeah. So with mental health specifically, definitely the connection between the two is sort of clear because I think, and it is primarily stigma based because a lot of people with mental illness will find themselves disproportionately living in poverty for two reasons. One, because in the event that their mental illness does render them unable to work, the support really isn't there to help them. And two, because I think when we talk especially about private employers, the tendency can be for, once they disclose that they're suffering from a mental illness, for whoever they disclose it to kind of think of them as somebody who might not be capable of doing the job, even when that's not the case. But I think mental health really, when we talk about that in terms of stigma, I think, especially when we talk about, and it does happen within mental health care too, but especially when we talk about healthcare outside of mental health care, that can be a place where people really, despite their efforts, can tend to reduce people down to being just their illness, which to a large degree, I think, is influenced by some of the liability issues that exist. You can open yourself up to all kinds of lawsuits if you don't take into account someone's mental illness, if they're making sort of a big decision and later they or a family member kind of try to say that wasn't actually was a decision they made sort of freely. But I think we see it manifesting in ways sometimes that go beyond that. It can be a mixed bag in terms of the stereotype itself. So when I talk about both flattening people to that aspect, but also flattening that aspect, I don't think there's a lot of the aspect flattening. We've definitely, I think, come a long way, especially in the healthcare field, at acknowledging that things like depression or anxiety or OCD or autism, for that matter, can look like a lot of different things for a lot of different people. Although that being said, I'd be lying if I said the stereotypes have gone away completely. When I mentioned earlier I have OCD, a lot of times I tell people that if I tell people that at work, the response tends to be, "But your office is so messy." Well, no, I don't have that type of OCD. But when it comes to, I'll get a little bit more personal here. When it comes to autism, I really went back and forth on whether I should disclose that I probably have autism in this, even in this space, because it's one where the stigma can hit me a lot when I'm not expecting it to, and it can become really sort of overwhelming and immediate. A lot of people, I think, still don't really know what autism is, and I think that's really manifesting the fact that a lot of people don't know what it isn't. When I tend to disclose that I'm probably autistic, people usually, they start treating me like I'm cognitively impaired, or they start treating me like I'm a robot with sort of no real feelings. And really, for me, it tends to just be that I sometimes struggle with social cues, and occasionally my face and my voice don't match my mood. But beyond that, my moment-to-moment experience of just everyday life, including the overwhelming majority of interactions I have with people, really isn't different than anybody else's. But the level of misinformation I think that exists can be really staggering. And I think a lot of it comes from the fact that a lot of what we consider the most mainstream sources of information, I'm only going to list one example, so hopefully I don't get in too much trouble. The organization Autism Speaks is awful for this. A lot of their mainstream sources of information don't really base themselves on some of the most up-to-date research, and they don't really tend to center the experiences of autistic people. I know there was a big news story about a year ago. The singer Sia made a movie about a woman looking after her autistic sister, and it was just like full of stereotypes. And it was really, the movie got panned. It was a commercial failure. It bombed. Everybody was really mad at her. And I actually found myself not really being able to be particularly mad at her, because I asked myself, are any of the stereotypes presented in this movie any different than what someone would believe if they just Googled information about autism? And to bring it back to this idea sort of reducing people to their mental health conditions, I think the best way to put it, why I'm so selective of it, in the chat, the movie Music, yes, that was the one. To bring it back to sort of why I'm so selective about who I tell, is that when I tell them I'm autistic, they tend not to hear I'm autistic. They tend to hear I am autism. As in that's all they really need to know about me from that point going forward. When in reality, I would say it's like 10th on the list of things about me in order of what I'd consider to be important. And if anybody's wondering if I've actually ordered all of the things in my life, as far as no, I haven't. Part of me wants to say that that would be buying into the stereotypes, but part of me realizes that actually is exactly the kind of thing I would do. But I think it's something that we see also broadly with more mental health issues. I know a lot of people, if depression or anxiety is listed anywhere in their patient history, they can dread going to the doctor because they know that they know that whatever is wrong with them, it might take 1 or 2 visits just to get it through, sort of clearing up that that's not just the anxiety talking. That's something that happened to me a couple of times. It took me about 6 visits with my own family doctor to get him to put in a referral to a specialist, because we kind of just had to clear through, like, no, it's not just in my head, it's definitely happening. And when I got to a specialist, it took about 5 seconds, like, oh yeah, I did 1 test, that's what's wrong. And I don't want to give the impression also that we shouldn't factor in those things, because for every time that's been what's happened, there's been a time that it actually did turn out to just be in my head, or even in those times where it wasn't in my head, the anxiety definitely didn't help. So it was always kind of part of the conversation. But I think it can be kind of the difference between moving forward as though something might be a possibility and going forward as though it's the main possibility that we have to rule out before we can talk about anything else. Now, the one mental health condition I do want to talk about that I don't think I could go without mentioning, just because I think if we're talking about stigma, I think it's kind of the sort of the biggest one that I notice is a lot of stigma around it, and that would be borderline personality disorder. I've never seen a condition be more misunderstood by the general public. I don't have it myself, but 3 people in my life who I've known and cared a lot about did, and I think that might kind of be why it bothers me so much. The first time that I ever heard the phrase borderline personality disorder, the person who was telling me about it, who I should have had a degree in psychology, told me, and I quote, "It's like the female version of being a sociopath." I can think of 3 reasons off the top why that's wrong. First, because there's no such thing as male or female versions of any mental illness. There's no such thing as male or female brains. There's average differences, but there's not like a concrete. Anyway, the second is because, well, 75% of people diagnosed with BPD are women. It's in no way exclusive to women, and we haven't really ruled out the possibility that discrepancy might be because we're so more readily willing to diagnose it in women. But the third, and I feel probably the most important, is that borderline personality disorder is actually nothing like being a sociopath. In fact, in a lot of ways, I would consider it to be pretty diametrically opposed. And even sociopath isn't always a perfect term either, because it tends to sort of be a colloquial clumping together of a lot of more complex terms. But when we think of a sociopath, they tend to be cold and calculating. Well, BPD tends to manifest in really the outright inability to hide one's feelings. We always think of a major component of sociopathy as being lack of empathy. Well, people with borderline personality disorder find that they feel everything more intensely, including empathy. And then the other stereotype, there's sort of 2 main stereotypes I find. I find people operate usually under one or the other. That one I would call the not quite sociopath stereotype, and the other, the other is what I would call the sort of just plain crazy stereotype, which is where we tend to. I lost my train of thought. Sorry, I've got my notes. I've actually had like certified clinicians tell me, oh yeah, I've worked with people with borderline personality disorder before. They're just plain crazy. Like, they're just crazy. And first of all, I don't think the word crazy should ever be used in a mental health setting. I think it should be treated as useless and meaningless. But I think we also need to note that what they really mean when they say that is there is this idea that there's no sort of logic or reason behind someone's actions, which is not really grounded in reality. It is true that depending on which study you read, about a fifth or somewhere between a fifth and half of all cases of BPD do come with some symptoms that are similar to psychosis. But usually we're not referring to that. We're referring to sort of the intense emotional outbursts or the unstable moods or the tumultuous interpersonal relationships. And the thing is, those don't come from nowhere. A lot of people with borderline personality disorder, the sort of chief symptom that they really report is that they feel like every emotion they feel is just like, it's like a stereo turned all the way up to the maximum volume. And so a lot of what can look like it came out of nowhere. It really just came out of somewhere that we wouldn't recognize as causing that magnitude of a reaction. Which is not necessarily to say that the reactions are completely rational, but they're also not. They're not coming from nowhere. They're not coming from nothing. And when we call somebody crazy, what we really do is we sort of find a way to dismiss all of that. And I think what both the not quite sociopath stereotype and the just plain crazy stereotype have in common is that they both kind of allow us to slip into a pattern of explaining everybody or everything that I'll try that again. Everything that somebody does just using their personality disorder. And it shuts us off from the possibility that what they're doing might be, certainly that's part of the explanation, but that there might also be part of it that's coming from something that might be relatable, that might be understandable. That what makes other people tick is the same thing that makes us tick. It just makes them tick a little differently.
And I'm just picking up, there's some comments in the chat, just this continual sort of reflection that you have around stigma, this flattening, this lack of dimensionality to people, and just picking up what Diane Delva is talking about, and just, seeing people as individuals versus the diagnoses. There's also two other comments here. Anna Reardon has commented, sort of in addition to Elliot's comments, about access and, the ability to regularly access care, and thinking about virtual care, and your thoughts about access and equity to access with virtual care. I don't know, Anne, if that's what you're alluding to as well.
Well, I know with specifically talking about virtual care, for obvious reasons, it's had to become a lot more normal in the past couple of years. But a surprising number of people still don't have internet. And I think to that end, if we kind of go back to community solutions, some people have proposed universal internet, and it's not a bad idea.
Mm-hmm, mm-hmm. Elliot, I see you're on camera. I don't know if you have a follow-up to that question. I'll circle back, Ian, to the last question of the night.
Yeah, Ian, I made the comment. I do health policy research specifically in primary care, and we know that attachment to a primary care provider is related to income level, and people at the lower income levels have poor attachment to their family physician or other primary care provider. And I'm just wondering on your comments on how you've experienced that with some of the people you work with, or is that a problem that they report to you?
There's definitely, I definitely see a higher percentage of sort of people with. Are you talking about people without a family doctor, without access to one?
Correct. Yeah.
Yeah, I definitely see a lot more overlap when people are living in poverty, or especially if they're dealing with addiction. I think it can come down to a couple things. I know physical access and proximity to healthcare providers can sometimes depend a lot on where one lives and the economic status of the sort of average economic status of people living in that neighborhood. I think beyond that, I also would say a lot of it comes down to, I think people can find themselves without access to a primary care physician, and depending on how much else is going on in their life, it can sort of fall through the cracks as something that they know, A, that they have to fix, and B, how to fix. I know if tomorrow my family doctor was to retire and not name a replacement, I would know what to do, and I would know where to go, and I would feel confident in filling out those forms. But I think for a lot of people dealing with, and this kind of ties back to the story of my one friend, and sort of the idea that living extreme poverty can be a full-time job. I think there are some people where they aren't able to get around to it because there's sort of always one emergency or another happening. And we also do have a shortage of doctors. That's a pretty indisputable fact. I think ideally we would have a system wherein nobody really has to go looking for a doctor, so to speak, where nobody has to, go on a wait list. or even fill out particularly complicated forms.
And I know
I hope I've answered the question.
I think, yeah, no, that is so challenging, and just reflecting on the complexities of life in poverty and the time it takes just to simply live. And I know you've touched on a few strategies already today, and so just thought we'd sort of end on maybe one or two reflections about everyone around the call here is either a recipient or a provider of care in some form. One takeaway to suggest about how to address stigma as we sort of end the call and move on our day tomorrow, or the rest of the day, that you could share with us that you might suggest to us?
I think if I had sort of one takeaway, it's that I think, and this goes back to community health, I think, I know one major theme of the last time I spoke was this idea that the healthcare community and the activist community are made for each other. And I think I'd really like to underline that again, because I think what we've talked about a lot here has been the need for greater community resources to be available. And I think there's a lot of potential for the medical field, and people in the medical field to sort of be at the forefront of that advocacy. And I think that's definitely kind of the main thing that I think, if I had to summarize kind of what I would say as to how to go forward, I think that would be it.
Thanks, Ian. I think that's something, oftentimes maybe it's out of our comfort zone, but it's the ability to use the privilege that we have in these roles. And I think that it's a great takeaway to think about as we start our day tomorrow. Ian, I just want to say on behalf of our group and everyone on the call, what a privilege it was to hear you speak and reflect on your experiences and that of those that you've worked with. I know in preparation for today, you've made me think greatly, so I hope everyone else has had that same privilege today.
Thank you. And thank you so much for having me. This whole series has been great. And thank you everybody who showed up. I just, everybody who's attended this, I think has already definitely taken the first several steps to putting in the work. Because not everybody recognizes the need even to have these discussions. And I think by attending today, everybody has shown a tremendous amount of willingness and a tremendous amount of foresight and bravery, even, really.
Well, thank you for being brave and sharing with us today, and I really appreciate it.
Thank you.
Thank you. Thanks, everybody.
Thank you. Bye-bye.
Thank you.